Good afternoon, dear listeners. My name is Abramyan Arevik Armikovna, and today we are going to talk about dementia with Lewy bodies. Dementia with Lewy bodies is a dementia clinically defined by Parkinsonism syndrome and the onset of progressive cognitive impairment within the first year of the disease. Recurrent visual hallucinations and significant fluctuations in attention and intellect throughout the day are characteristic. History. The disease is named after the German neurologist Friedrich Lewy, who described Lewy bodies in 1912. In one of the chapters of his book on Parkinson's disease, he first described the bodies named after him in 1917. Working in a Berlin clinic, he discovered these changes in the basal and dorsal nucleus of the vagus in patients with Parkinson's disease. The etiology of the disease remains unclear. Most cases of the disease are sporadic. The detection of a high frequency of the ApoE4 allele on chromosome 19 in patients with dementia with Lewy body indicates the existence of a hereditary predisposition and allows dementia with Lewy body to be classified as a multifactorial disease that arises as a result of the interaction of genetic and exogenous factors. Modern immunocytochemical studies have shown that the main component of Lewy bodies is alpha-synuclein, which allows dementia with Lewy body to be classified together with the group of synucleinopathies. However, given that beta-amyloid also accumulates in the brain of the vast majority of patients with dementia with Lewy body, this disease should rather be classified as synuclein amyloidopathies. It's assumed that the formation of Lewy bodies is associated with the aggregation of alpha-synuclein due to changes in its conformation, excessive formation, impaired metabolic degradation in the cell, or disruption of its axonal transport. Oxidative stress and microglial activation may play an important role in the pathogenesis of cell death. In this picture, we can see a neuron with Lewy bodies. This picture shows microscopic image of nerve tissue with Lewy bodies. Classification. There is no generally accepted classification. Based on the clinical picture, neuroimaging data, and pathomorphological changes, three subtypes of dementia with Lewy body are distinguished. First, classical subtype with typical polysyndromic manifestations. Second, subtypes with early psychotic disorders. The development of visual hallucinations precedes cognitive decline. Third, mixed subtype with a combined neuropsychological profile, including, along with impaired executive functions, amnestic disorders of the Alzheimer's type, and a decrease in semantic speech activity. Clinical manifestations. Clinically, Parkinsonism syndrome and progressive cognitive impairment are determined without significant memory impairment. Cognitive impairments are primarily manifested in a progressive limitation of visual-spatial perception and attention. The onset of intellectual function impairments in the presence of Parkinsonism for no more than 1 year is characteristic. Marked fluctuations in cognitive impairment and wakefulness throughout the day are specific, sometimes even with unresponsiveness to address, with an absent gaze. Recurrent, vivid, and memorable visual hallucinations, animals, people, scenes, etc. Frontal functions may be limited, but not severely, and they do not significantly worsen during the course of the disease. Diagnostic criteria for dementia with Lewy body, according to McKay et al. A prerequisite for diagnosing dementia with Lewy body is a progressive dementia syndrome. Marked and/or persistent memory impairments are not obligatory in the initial stage of the disease and usually appear later. The clinical picture is typically dominated by deficit in attention and visuospatial perception. Cardinal symptoms are fluctuations in brain function, especially regarding wakefulness and attention. Recurrent visual hallucinations, typically detailed and clear. Parkinsonism syndrome. A diagnosis of dementia with Lewy body is possible if one of the cardinal symptoms is present. A diagnosis of dementia with Lewy body is probable if at least two cardinal symptoms are present. Typical symptoms: REM sleep behavioral disorder, Schenck syndrome, talking or shouting during REM sleep, motor expressions of dreams, severe neuroleptic sensitivity, reduced striatal dead binding on SPECT or PET. If one or more typical symptoms occur in the presence of one or more cardinal symptoms, a diagnosis of probable dementia with Lewy body can be made. If cardinal symptoms are absent, at least one typical symptom is sufficient for a diagnosis of possible dementia with Lewy body. A diagnosis of probable dementia with Lewy body cannot be made based solely on typical symptoms. Other symptoms: recurrent falls or syncope, brief losses of consciousness, severe autonomic dysfunction, hallucinations of other senses, systematized deletions, depression, relative preservation of mesotemporal structure on SPECT or PET, including occipital structures, marked slowing of waves on EEG with transient temporal sharp waves. A diagnosis of dementia with Lewy bodies is unlikely. In cerebrovascular diseases with focal functional deficits or structural abnormalities on computer tomography or MRI. In other brain diseases or systematic disease that can explain the clinical picture, when Parkinsonism occurs, is an advanced stage of dementia. Temporal sequence of symptoms. A diagnosis of dementia with Lewy body is valid only if dementia occurs no later than 1 year after the onset of Parkinsonism syndrome. A diagnosis of Parkinson's disease with dementia is valid if dementia symptoms occurs against the background of advanced Parkinsonism. Neuroimaging. Computer tomography and MRI. Typically, minor brain atrophy is detected. PET. Hyperperfusion and decreased metabolism in the occipital and parietal regions, as well as dopaminergic associative dysfunction in the striatum are characteristic. Differential diagnosis. It's primarily conducted with Alzheimer's disease. Visual hallucinations and limitations in visuospatial perception are highly specific for dementia with Lewy bodies. Also, fluctuations in cognitive function throughout the day are characteristic of dementia with Lewy bodies and atypical for Alzheimer's disease. Differential diagnosis is also performed with Parkinson's disease. Treatment. For the correction of cognitive impairments in patients with dementia with Lewy body, anticholinesterase agents are recommended as first-line drugs. For the correction of cognitive impairments in patients with dementia with Lewy body, in cases of intolerance or insufficient effectiveness of anticholinesterase agents, memantine is recommended both as monotherapy and in combination with anticholinesterase agents. For the correction of fluctuations when anticholinesterase agents and memantine are insufficiently effective, small doses of atypical neuroleptics or antipsycholytics may be used. In the event of psychotic disorders in patients with dementia with Lewy body, it's recommended to, first, identify and correct precipitating factors, for example, infections, dehydration, metabolic disorders, somatic diseases, etc. Second, reduce the dose and or discontinue certain anti-Parkinsonian drugs. Acetylcholinesterase inhibitors have an effect against hallucinations and cognitive deficit. They are the drugs of choice before prescribing psychogenic medication. Rivastigmine is used. Thank you for your attention.